Okay, so today we're going to be talking about Module D, Immune System Alterations. Now your readings for this are going to be in your IGGY 7th edition. It's going to be in various chapters. Mostly it's going to be focusing on Unit 5 in your book. So the immune system is composed of many interdependent cell types that collectively protect the body from bacterial, parasitic, fungal, and viral infections, and from the growth of tumor cells. Now these cells have specialized functions. The immune system protects the body by neutralizing, eliminating, and destroying invading organisms. So the cells of the immune system can engulf bacteria, they can kill parasites, they can attack tumor cells or kill viral infected cells. Now often these type of cells depend on the T helper cells for activation signals in the form of secretions known as cytokines, lymphokines, or more specifically interleukins. So the immune system is made up of several different things. Encompasses immunity, inflammation, infection, tolerance, autoimmunity, and antigens. Now, an antigen is a substance that introduces the formation of antibodies because it's recognized by the immune system as foreign to the body. Now, if the body detects an antigen that's previously met, a specific immune response occurs. In this response, the body has been trained to recognize and neutralize familiar specific antigen. Its immune system remembers the antigen. Such systemic at least not restricted to the initial infection site. Immunity enables a faster, longer lasting immune response that does have a non-specific response. Now, when antigens successfully invade the body through the skin or mucous membranes, their presence elicits an inflammatory response. Now, this response prevents the antigen from spreading to nearby tissues. It disposes of cellular debris from the battle and begins to damage the repair. Now, when the invasion starts, the immune system sends its what we call soldiers, which is leukocytes or white blood cells, to the battle. Now, leukocytes such as neutrophils and macrophages ingest and destroy the antigens in the process, and this is called phagocytosis. Now, if a bee stings you, the presence of the bee venom triggers a non-specific immune response. So white blood cells arrive first to the scene. They try to get rid of the V venom antigens that are in the body. Now, as the war goes on between the antigens and the white blood cells, you're going to see signs of that battle. May appear as redness or inflammation on the affected skin. So inflammation, redness, swelling, heat, pain, all these are results of the infection being fought as far as the white blood cells and the antigen. Now, on this slide here, slide 6, you're going to see that the slide illustrates a continuum related to the immune system homeostasis. Now, for the optimal response for the scope of immunity, you're going to have several different things going on. So for the scope of immunity, for the optimal response, you're either going to have a suppressed response or an exaggerated response. Now, the primary functions of this optimal response are going to be to protect the body from invasion. It's also going to remove the dead or damaged tissue or cells, and also going to recognize and remove the cell mutations. Now, as far as natural or innate immunity, your first line of defense is also always going to be the skin. Other lines of defenses that are on the first line, your fluids or secretions, bone marrow, your thymus, your spleen, and your lymph nodes. Now, your second line of defense is going to be your white blood cells, and that's going to be through phagocytosis and inflammation. You're going to see that second line of defense. Now, your third line of defense is going to be your acquired immunity. So it's going to be your antibodies that you have built up, cell-mediated immunity, and your tolerance to the invader. Now, there are three different divisions of immunity. Your inflammation, which is your natural immunity. Now, inflammation is your first division of immunity. Your second division is going to be your antibody-mediated immunity, or your humoral immunity. And your third is going to be your cell-mediated immunity, which is cellular immunity. Your inflammation, which is the same as innate or native immunity or natural immunity. Is going to be your first division of immunity. Now, the process, the first process, like we talked about, inflammation, gives us an immediate protection from tissue damage or invading organisms. It's any natural protective feature a person has. So it can be a barrier or an attacking force. It cannot be developed or transferred, and it is not an adaptive response to exposure or invasion of foreign proteins. Now, inflammatory response is a part of innate immunity. Excuse me. It also includes the skin, the mucosa, the antimicrobial chemicals on the skin, and these can complement and kill cells. Now, what makes inflammation different from antibody-mediated and cell-mediated immunity is that it is immediate, but it's short-term. So it works against the injury or organism. Inflammation also doesn't provide true immunity or repeated exposure to the same organism. Also, you're going to have a difference because it's a non-specific body defense to injury or organism, and it can be started quickly and almost in any event. So, an example would be a burn. The inflammation response to a burn, it would be the same as, say, having a bacterial infection in the middle ear. Now, how much of the body is affected by the inflammation depends on how intense or severe and how long the exposure is. So, infection usually goes with inflammation, but inflammation can occur without infection. Okay? So, infection usually goes with inflammation, but inflammation doesn't necessarily have to go with infection. So inflammation doesn't always mean that infection is present. Now, what are the cell types that are involved in inflammation? We know that there's neutrophils, macrophages, eosinophils, basophils, neutrophils, macrophiles. All these use phagocytosis, or they engulf and destroy and try to eliminate any kind of foreign invaders. Now, your baso and eosinophil release chemicals that act on the blood vessels to cause the tissue level responses that in turn help the neutrophils and macrophiles actions. And there's also 7 steps to phagocytosis, and these are noted on page 308, figure 19.6 in your books, if you'd like to look at that. You won't need to know the 7 steps, but if you're interested in the 7 steps, that's where they're located. Now, you need to make sure you review the description, origin, and function of each of the different cell types, just so you'll have a good idea on which cells react in which ways. So let's look at some differences in the inflammatory response. Now, hemodynamic changes, you're going to have dilation of the capillary bed. You're also going to have an increase in the blood flow to that area. So there's going to be warmth and redness at the site of the inflammation. You're also going to have increased capillary permeability. So your chemical mediators are going to cause leukocytes to line the small blood vessel walls near the inflammatory site. Now, these cells are going to pass through the walls and they're going to inhabit the inflamed area. They're also going to ingest and carry away. It's going to help to ingest and carry away the bacteria and other foreign substances that are in that area. Now, the permeability of these vessels causes protein-rich fluid to flow through the vessel walls into the interstitial spaces. And the collection of fluid is responsible for the swelling in these areas. Now, the hemodynamic changes in the vascular permeability occur with the help of several chemical mediators. And these are going to be prostaglandins, histamine, and leukotrienes. Now, these are powerful substances found in various body tissues, and they're liberated during the inflammatory process. Now, cytokines and eicosanoids are also used in this process, and these cause blood and the blood vessel changes. Now, bradykinin is also produced, which also mediates the blood vessel dilation and permeability. And a lot of times this is going to produce pain, and that's another classic sign of inflammation. Now, you're going to have 3 stages of your inflammatory response. Your first stage is going to be the vascular part of the inflammatory response. Now, Stage 1 involves changes in the blood vessels like we talked about. It's these changes that cause the redness and warmth. The increased blood flow to the area increases the delivery of the nutrients to the injured tissue. Now this blood flow results in hyperemia and edema. The capillaries leak and they let blood plasma into the tissue. Now this helps to cause swelling and pain, but it also helps to protect the injured area by providing a cushion of fluid that can dilute the toxins that have entered into that area. Now duration of this usually depends, but it usually depends on the infection, but usually lasts anywhere from 24 to 72 hours. Now macrophages are usually the major cell in stage 1. They have a rapid but a limited action. So to enhance the response, the macrophage secrete cytokines. Now one of these is a colony stimulating factor that makes the bone marrow go into overtime. So instead of the usual 14 days to produce white blood cells, it only takes a few hours. Now other cytokines increase the release of neutrophils from the bone marrow and attracts them to the injury site. So that begins stage 2. Now stage 2 is the cellular exudate part of the inflammatory response. Stage 2 includes neutrophils, which are the most active cells in this stage, and can be included can be increased up to 5 times within the first 12 hours of the onset of inflammation. Now the exudate forms pus containing dead white blood cells, necrotic tissue, and fluids from the damaged cells. Now neutrophils attack and destroy and remove this through phagocytosis. At the same time, the bone marrow is also triggered to produce monocytes. This is a slower process, but it has a longer lasting effect. And stage 2 produces a cascade of substances known as mediators because they keep the inflammatory process going. Now mediators include histamines, leukotrienes, prostaglandins, serotonin, and kinins. Now the anti-inflammatory drugs that are used during this period usually include NSAIDs, and these help to stop this cascade process. Now normally an infection lasting a few days, the bone marrow can keep pace with the infection and produce enough mature neutrophils. Now if it's prolonged, the bone marrow falls behind and releases immature neutrophils in an attempt to keep up. Now this limits the effects of the inflammation and increases the risk for sepsis. So next we move on to stage 3, which is basically tissue repair and replacement, and this begins at the time of injury and is completed lastly. Now stage 3 is critical to the final function of the inflamed area. White blood cells involved start to repair by inducing healthy cell division. In tissues that can divide, it causes angiogenesis, which is new blood vessel growth, or scar tissue formation. Now since scar tissue isn't like the tissue it replaces, then function is lost in that area. So inflammation itself cannot provide immunity It's the interaction of the inflammatory cells and the lymphocytes that provide long-lasting immunity. Now, long-lasting immune actions develop through antibody-mediated immunity and cell-mediated immunity. So this just shows the different things that cause inflammation. Okay, so you have causes and effects. So immunity and infection both cause inflammation, but the effects of that inflammation are going to be tissue integrity, thermoregulation, gas exchange, clotting, fatigue, stress. All these are going to be effects of this inflammation. So your second process is known as antibody-mediated immunity. Okay, we talked about inflammation. Now we're going to talk about the antibody-mediated immunity. Now this is also known as humoral immunity, and it involves an antigen-antibody interaction to neutralize, eliminate, or destroy the foreign protein. Now these antibodies we're talking about are produced by a sensitized B lymphocytes or B cells. And the B cell becomes sensitized to antigen and produces antibodies specific to the antigen. Now, it's the antibody rather than the B cell itself that starts the actions that do the neutralizing, eliminating, or destroying. Now, B cells are the most active cells in the antibody-mediated immunity. Now, MACs and T cells also work with the B cells to start a complete antigen-antibody interaction. Now, for the AMI to be optimum, the entire immune system has to be functioning adequately. So your B cells come from the bone marrow as stem cells, and they take a lymphocyte pathway through the blood to settle in a secondary lymphoid tissue. Now, this is going to be found in the spleen, parts of the lymph nodes, tonsils, the mucosa of the intestinal tract, and this is where the maturation is completed. So the 7 steps to produce specific antibodies is going to be exposure or invasion. So for exposure, for antibodies to exert effects on a specific antigen, they must first enter the body. So you're going to have exposure or invasion. Now your antigen recognition is where your B cells recognizes the antigen as a non-self, which requires help from the macrophages and the T cells. Your sensitization is where your B cells become sensitized, to that one type antigen, that one type invader that's going on. Okay? Your production, antibody production and release allows the antibodies produced by the plasma cells to seek out the antigen. Your antibody-antigen binding is where the antibodies are excuse me, where the antibodies are bind to the antigen. Now it doesn't kill the antigen yet, but they bind to it and helps the white blood cells to stick to and attack the antigens. Now your antibody binding actions cause the reaction that neutralize, eliminate, destroy the antigen through agglutinin, lysis, inactivation, and neutralization. And your sustained immunity, or your memory, is the long-lasting immunity specific to that antigen. So the body remembers that antigen. Okay. Memory cells make a new sensitized blast cells and plasma cells. So when the body's re-exposed to that antigen, it produces large amounts of the antibody that helps prevent the patient from becoming ill again if they're exposed, even if they're exposed many times, because of the rapid and immune response that the body has to that antigen. So adaptive immunity is the immunity your body either learns to make or can receive as a response to invasion from foreign organisms. Now this can be an active or passive. Now your active immunity occurs when the body actively makes antibodies against an invading organism, either under natural or artificial conditions. Now your natural active immunity would be when the organism enters the body without human intervention, and the body responds by making antibodies. Now this type of immunity is the most effective and the longest lasting. An example of that would be chicken pox. Your artificial active immunity would come from the body's active response to a vaccination or immunization. Now this is used to prevent used in a preventive manner. This type of immunity lasts many years, but it does require a booster, which is basically a smaller dose of the original antigen to retain the protection. So, like your tetanus shot, it only lasts a certain amount of time, then you have to be re-immunized with or have a booster of your tetanus shot. Okay. Passive immunity basically occurs when the antibodies against the antigen are in the body but are not created there. So these antibodies are transferred into the body after being made by another human body or an animal. Now the problem with this is that the body didn't make it so it's seen by the body as a non-self and is usually eliminated quickly. Now this type of immunity provides only immediate short-term protection against a specific antigen. Now it can be either natural or artificial. Now your natural passive immunity occurs when antibodies are passed from a mother to a fetus through the placenta, clostrums, or the breast milk. Now your artificial passive immunity involves the injection of antibodies created in another human or animal, and this type of immunity is used when a person is exposed to a serious disease that the person has little or no actively acquired immunity. So this type of immunity is temporary lasting, and it could be for only days or weeks. Example of this, like we said, is like rabies, tetanus is an example, a snake bite. So now we're going to talk about cell-mediated immunity or cellular immunity. This protects the body through the ability to detect self from non-self. Now, these cells most often are target cancer cells and cells infected by an organism that requires a host to live. Now, cell-mediated immunity is important in preventing the development of cancer and metastasis after exposure to carcinogens. Now, cells involved in the cell-mediated immunity are going to be your white blood cells, and these are going to be specific to the T lymphocyte or T cells, the natural killer cells. Now, the 3 T cells that are critical for cell-mediated immunity are the helper T cells, the suppressor T cells, and the cytotoxic T cells. Now, your helper T cells are going to recognize self cells. When the helper T cell determines a protein is not self, it secretes lymphokines that enhance the activity of the other white blood cells to increase immune function by increasing bone marrow production of stem cells, and speeds up the maturation of these stem cells. Now, your suppressor T cells help to regulate cell-mediated immunity through prevention of hypersensitivity, and this is continuous overreactions when a person is exposed to non-self or an invading body. Now, this function is essential to in inhibiting the body from attacking normal healthy self cells. Now, if these cells don't adequately perform their functions, then you have the basis for an autoimmune disease. Now, we'll discuss that in a few minutes, but your helper cells and suppressor cells have an opposite reaction. So the cell-mediated immunity process, for the cell-mediated immunity process to be effective and adequate, there's got to be a balance between these two. The balance usually occurs when the helper cells outnumber the suppressor cells 2 to 1. So, if there's too many helper cells, basically what you're going to have is you're going to have an overreaction, and usually from the body to the response to the body, and tissue damage can occur during this time. Now, also is true if there's too many suppressor cells. So the immune system is going to be suppressed, and they're going to have a high risk for infection. Now, your cytotoxic T cells are capable of inducing the death of infected or tumorous cells. Now, they kill cells that are infected with viruses or other pathogens, or cells that are otherwise damaged or dysfunctional. Now, cytotoxic T cells bind with the infected cell and create holes in the cell membranes to deliver specific enzymes, causing lysis. Then they turn loose and they go fight with the same antigen. Now, your natural killer cells, they're not a true T cell, but they act like a cytotoxic T cell. Basically what they do is they bind to the targeted cell and release enzymes to create holes in the cell membrane. Of the targeted cell, through which the enzymes can enter, causing death to the virus inside. Now, the distinction between cytotoxic cells and natural killer cells is that the cytotoxic cell must be sensitized and then rally other white blood cells to fight. Natural cells don't have to be sensitized first. They're on the search and destroy mission against non-self cells. So normally cancer cells and virally infected cells are what they go after. So to the far left of the immune response spectrum is a hypo or suppressed immune response. Now, individuals who have a suppressed immune response are referred to as immunocompromised or considered to be in a state of immunodeficiency. Now, being in a state of immunodeficiency equates to the inability to produce a normal complement of antibodies or immunologic sensitized T cells in response to specific antigens. So your primary immunodeficiency occurs as a result of improperly developed cells or in an absence of cells required to execute their immune response. So your secondary immunodeficiency is a loss of the immune functioning as a result of illness or treatment. Now, regardless of the type, these clients are at risk for infection of cancer. Now, on this slide, you see to the far right of the immune spectrum is the hyperimmune or exaggerated immune response. Now, considering the hypo response, you might think that this is the best thing that could happen, but it's not. What we see is a typical immune response that's activated by a foreign substance that normally is inoffensive or an allergy. Now, the tendency to develop an allergy is inherited, although the type of allergy may vary. An antigen that causes hypersensitive or exaggerated immune response is also called an allergen. Now, your autoimmune conditions are also going to be in a category of exaggerated immune responses. Now, the different things that can cause patients to be at risk for exaggerated responses, it could be their gender, their race, their ethnicity, per condition. So your people with SLE, women to men, are going to be 10 to 1. African Americans are going to be 8 times more apt to have SLE than Caucasians. Genetics sometimes require both parents or one parent to carry a gene or chromosome with an environmental or physiological trigger such as puberty to take effect. Environmental or medication exposure to a foreign antigen. So you could have allergies to foods, drugs, pollens, dust, mold, bee venom, vaccines, serums. All these things can cause allergens. So, effects of aging on the immune system. Basically, you're going to have a decline in the immune system. So, you're going to have a greater instance of tumors. They're going to have a greater susceptibility to infections. Basically, your thymic involution, which basically is where your thymus shrinks, so they have fewer T cells to fight infections. Your cell-mediated immunity decreases. Also, there's a decrease in delay in the hypersensitivity reaction, so your bone marrow becomes less productive. The lymphatic tissue shrinks, so that results in fewer and smaller lymph nodes. And the immunologic function, sorry, I'm not very good at saying these words. are not affected unless a person is usually stressed by trauma or chronic infection or treatment for cancer. So, what you're going to see that infections in older people are going to be less evident, and it's going to take older folks a longer recovery time to fight back from having an infection. So, let's look at 10 warning signs or signs and symptoms of primary immunodeficiency. So primary immunodeficiency is a situation where an entire immune defense system is inadequate, and the individual is missing some, if not all, of the components necessary for an immune response. Now, the National Institute of Health put out a list and has identified 70 different types of immunodeficiency. So, 10 warning signs of primary immunodeficiency. If somebody has 4 or more new ear infections a year, if they have 2 or more serious sinus infections a year, if they have 2 or more months of taking antibiotics with little effect, 2 or more pneumonias a year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infection on the skin, the need for IV antibiotics to clear infections, 2 or more deep-seated infections including septicemia, or a family history of primary immunodeficiency. So let's look at hyperacute rejection, acute rejection, and chronic rejection. So killer cells and T cells destroy cells. Normally this is a good thing and is helpful to the body, but it also is responsible for transplant rejection. Now, rejection can be hyperacute, acute, or chronic. So, hyperacute usually begins immediately and is an antibody-mediated response. It occurs most likely in kidney transplants, but it's less common now. Now, symptoms are evident within minutes of the attached organ to the patient's blood supply. The process cannot be stopped once it's started, and the rejected organ has to be removed. Now, acute usually begins a week to 3 months after the transplantation, and may occur sporadically after that time. First off, it's an antibody-mediated response that results in vasculitis within the organ. It's different from hyperacute in that the blood vessels necrosis leads to organ destruction instead of occlusion. Secondly, it's a cellular response. So T cells and natural killer cells enter the organ through the blood and start the inflammatory response, which causes the lysis of the organ cells. Now, the diagnosis is made through tests that show the impaired function of the organ through biopsy. Now, symptoms are going to vary from patient to patient, and also with the organ transplanted. Now, an episode of acute rejection after a solid organ transplant doesn't automatically mean that the patient will lose the new organ. Drug therapy to manage the recipient's immune response at this time may limit the damage to the organ and allow the graft to be maintained. Now, your chronic rejection is going to be a little more difficult but it's similar to chronic inflammation or scarring. The smooth muscle of the blood vessels overgrow and occlude the vessels. Then the transplanted organ gets replaced with fibrotic scar-like tissue, so the organ function is greatly reduced. This is long-standing and occurs continuously as a result of ischemia related to blood vessel injury. When fibrosis occurs to the organ, it becomes usually no longer functioning, and there's no cure but to have retransplantation. Usually using an identical sibling is the only way to prevent chronic rejection. Now with these patients, they're going to be on maintenance therapy as a continuous immune suppression, so they're going to take medications to make them immunocompromised or to slow down their immune response to rejection of the organ. Now, rescue therapy agents also can be used in replacement of the conjunction with the maintenance therapy drugs, and these agents are used for short term to combat acute rejection. And so, just to give you an example, I had a friend recently that passed away because of organ rejection. She had her mesenteric artery got occluded. She lost all of her. She lost her stomach, her intestines, her colon. Ended up losing kidney function, her liver. She had a complete organ transplant. Everything went well for the first 2 months, and then she had a rejection, where basically her body started breaking down the organs. And she ended up, she could not fight off the response. She was so immunocompromised from the medications and the rescue therapy, maintenance therapy and rescue therapy, that she developed sepsis and ended up dying because of it. So this is just an example of how organ rejection can, there's good and bad to everything that you do. If she had not had the organ transplant, she would not have lived. So sometimes in the medical field, it's a damned if you do, damned if you don't situation. Sometimes there's not a clear-cut answer. Sometimes, it's either you have this done and you may live, or you don't have this done and you may live a little bit longer, but you're going to die, type thing. So, it's not always a clear-cut answer. So let's look at autoimmune diseases. Auto means self. The exact causes and pathology of the autoimmune diseases are usually poorly understood, but many of these disorders cause severe illnesses and death. Basically, what it is the body's inability to determine self from non-self. It's also called tolerance. Now, your immune system reacts against and destroys its own tissues is what happens. The breakdown in tolerance and subsequent damage to self is called autoimmunity. Now, it's initiated when tissue injury, infection, or malignancy occur. Sometimes there's a genetic factor because autoimmune diseases tend to be familial. It also can involve any tissue or organ system. Now, autoimmune diseases cause injury in three ways. They basically affect the antibodies or cell surfaces. They can do this through the deposit of antigen-antibody complexes and also through the action of sensitized T cells. Now, your autoimmune diseases, medical treatment for these are going to be with corticosteroids or non-steroidal anti-inflammatory drugs, or NSAIDs. And these are usually used to treat inflammation. You're also going to see immunosuppressive therapies that may be tried to moderate the autoimmune response. Now, nursing care for these patients, you're going to have adequate rest, maintenance, and optimal hydration and nutritional status, and prevention of infection. So, you want to have a supportive atmosphere, important to enhance the patient's coping skills and promote emotional health. So what do you think is important with autoimmune? Frequent hand washing. Okay? If you have a cold, you want to make sure that you're wearing a mask, or anybody going in the room. They also need to make sure they wash their hands frequently. Okay? Now, one autoimmune disorder we're going to look at real quick is lupus erythematosus. Now, women are most often to get this, and usually between 20 and 40 years old, but they can be younger and they can be older. There is a possible genetic predisposition, so African Americans are more often affected than whites are. Survival rates of these are usually 95% if it's diagnosed and treated early. Now, there are two main classes of lupus erythematosus. Okay, now that we've said that, there's DLE, which is discoid lupus erythematosus, which affects only the skin, and only a small percentage of people have this type. Okay, the biggest one is the SLE, which is basically a chronic progressive inflammatory disease of the connective tissue. It causes major body organs and systems to fail. Also, there are spontaneous remissions and exacerbations of this. And the autoimmune process, or vasculitis, occurs. Now, drugs that can induce lupus-like symptoms or lupus-like syndrome are going to be your procainamide, hydroxyline, thorazine, and your INH, which is isoniazid. Your pathophysiology is basically of SLE is going to be that it's a chronic progressive inflammatory connective tissue disorder, like we talked about. it's an autoimmune process, and it causes major body organs to fail and systems to fail. Now, remember, DLE only affects the skin. SLE can damage the organs, causing vasculitis or vessel inflammation. This leads to O2 deprivation. These immune complexes also affect the kidneys, so the glomeruli they're going to affect also. So kidney function is going to be a problem. So here's a picture of somebody that has SLE or has lupus erythematosus. You notice the butterfly rash on the face, also the skin lesions on the hands, the redness. These are all symptoms. Now, with signs and symptoms, their skin, they're going to have a dry, scaly rash on the face, like we talked about, the butterfly rash, discoid lesions, alopecia. Musculoskeletally, they're going to have polyarthritis, so the small joints and knees. Osteonecrosis, so they're going to have bone necrosis from lack of O2. This is usually treated with steroids for greater than 5 years. They're also going to have muscle atrophy. Systemically, any of the systems can be affected. So you're going to have generalized weakness, fatigue, fever. You're going to be more apt to have pleural effusions, pneumonia, like we talked about with the glomeruli getting infected, your renal involvement, pericarditis. And with the renal involvements, you're going to have lupus nephritis, which basically is the leading cause of death. The kidneys shut down. There's no classic presentation, and there's an extreme range of symptoms. So any of these symptoms can occur. There's not one major thing that can occur that shows that they have this. The major manifestation, I guess you'd say, the butterfly rash on the face, comes and goes with flare-ups. SLE, with a flare-up of SLE, usually you're going to have fever with that. Now, pleural effusions or pneumonia usually occur in about 50% of the patients. They also have problems with anemia, leukopenia, thrombocytopenia. It can cause Raynaud's, which is red, white, and blue color changes, and pain in the fingers on exposure to cold in small percentages. The central nervous system can be affected. So they could have psychosis, they could have paresis, seizures, cranial nerve palsies, peripheral neuropathies are also common. So as you see, there's a major bunch of different signs and symptoms that occur with this disease. Now, what you want to do is assess for any kind of signs and symptoms of renal involvement, any kind of change in output, proteinuria, hematuria, fluid retention. The most common CV problem is going to be your pericarditis. So you're going to look for anybody that has tachycardia. You're going to assess for tachycardia, chest pain, and MI. From peritoneal involvement, you're going to look for abdominal pain. Psychosocially, you're going to be assessing for the disfiguring rash, how it affects them, So if they have a rash like that, they're going to have fear. They're going to want to avoid social gatherings. Could be withdrawn. They could have problems with anxiety, chronic fatigue, and weakness. So for a diagnosis of SLE, 4 or more criteria must be present. To make a diagnosis, so there's 11 criteria basically that 4 or more need to be met by. And you can see these on here, the different criteria on this slide. 28. Now for diagnostics with DLE, they're going to do a skin biopsy. So for SLE, they're going to do different tests, run different tests. They're going to do an smooth muscle antibody, renal function test, a ANA, CBC, and a ESR. These are all blood tests. Your treatment for your DLE is going to be a topical cortisone, such as Plaquenil. For SLE, it's going to be chronic steroid therapy. They're going to use Cytoxin, which is immunosuppressant, IV glucocorticosteroids. They're also going to do plasmapheresis. Some other things they're going to also use, NSAIDs, like we talked about, corticosteroids. It could be topical, oral, or IV. The Plaquenil, immunosuppressants, so your Rumatrex, Imuran, or your Cytoxin, all these can be used for treatment of SLE. So non-pharmacological treatment of SLE, you're going to do education. So you're going to teach them what to do, what to watch for. You're going to teach them to do skin care. If the kidneys are affected, they could be have a kidney transplant. Like we talked about, plasmapheresis, and they're also going to be treated depending on what system is affected in their body. So some nursing diagnosis. They could have fatigue, acute pain, impaired skin integrity, activity intolerance, ineffective therapeutic management, risk for infection, altered body image. We talked about patient education. You want to monitor, you want to teach them to monitor for flare-ups. if they have fever, when, and what to report, and teach them coping strategies. You also want to teach them to avoid long exposure to the sun, to wear long sleeves and a hat. If they do go out, they need to use SPF 30 or higher. They also need to clean their skin daily and avoid any kind of harsh chemicals to use on their skin. So you want them to use mild protein shampoos and soaps. Now here's some useful websites. The Lupus Foundation of America can give you more information. The American College of Rheumatology, the National Institute of Arthritis and Musculoskeletal and Skin Diseases. Now that's it for this portion of the Tegrity. The next one we'll begin will be with HIV/AIDS.